in pursuit of health and wisdom. Sapio with Buck Joffrey.
Okay, we're back here again. This is the second round of this battle to the death with Dr. Alan Viglione on
Literally to the death.
Yeah,
to the cardiovascular
kind
death.
of is actually battle to the death. Cardio IQ. So what we're doing here, if you haven't listened to the previous episode, we're going through a test called the Cardio IQ, which is really, I think, a very useful type of test to look at cardiovascular health. That's really not done, I would say, as a normal part of a workup, but part of our Medicine 3.0 thing. We're trying to get a little bit more information, trying to catch things before they become problems. So anyway, Dr. Viglione, welcome back.
Thanks,
I'm
buddy.
glad you came back. I was afraid that you were going to be so embararased by
I just run out the front door.
Yeah, by how many things that I had beaten you on in the first round that you wouldn't show up again. Which I wouldn't have blamed you, and have been fine. But thanks for coming back.
My
And
pleasure, Buck.
we've gone back. We've gone through a bunch of things already in the first round of this, which was lipid panels. We've gone through lipoproteins, apolipoproteins, inflammation, and now I think what we'll do is we'll get to the next thing, which is metabolic markers. And some of this stuff I think will, for people who've been listening to other episodes, will start to sound similar to what we've been talking about before. But again, this just emphasizes their importance when it comes to cardiovascular health.
Yeah.
So talk about metabolic markers in general. Like, why do we look at these things? What are they?
Yeah, well, so why do we look at these things? Because they portend immense cardiovascular risk. So the whole point of everything we're talking about right now is to identify those patients at highest risk that might actually benefit from intervention. And this is a classic deviation from the Framingham risk score, which is what we all learned about in medical school.
Right.
So the whole point of doing this process is to identify patients at heightened risk that would benefit from reversal sooner than later.
Right.
Now, I'd be curious to hear your take on the Framingham risk score and why it's just not sufficient. Why is the classic cholesterol panel just not sufficient to identify risk? My take on it is that A, it's short-sighted, and two, it just misses things.
Well, my understanding with the whole Framingham, the way that whole study is, the way we look at it is what your risk is, right? So, like, the problem is that it's if you take somebody that's moderately elevated, the way we used to look at it is, well, it's not really a problem. It's slightly high, go work out, go do something.
Yeah.
But if you multiply that moderate elevation times 20 years, you've actually created a completely unavoidable problem.
Yeah. I mean, well said. A completely avoidable problem.
Right.
So we're really trying to get ahead of the curve. And you can't get ahead of the curve without identifying those at risk. And I think the inherent problem in the Framingham risk score is that the variables that are in that score are not optimized.
Right.
I mean, like, think about it. Like, so we spent the last episode talking about apolipoprotein B, LP little a, LDL particle number as opposed to the concentration. And none of those variables are in the risk score.
Right.
So how reliable is it?
This is relatively new technology stuff. A lot of things we're talking about as well. But I think the idea is, well, listen, we have the technology now. We understand the importance of keeping these things at bay. And why are we still looking at this the way we used to look at it? How many years ago?
I agree. With 20 plus years, things haven't changed.
It's more than 20 years, right?
Yeah.
Yeah. But so that's the problem. So again, it is, we can get off of our high horse for a moment and go back to the battle, because I know that was really why you went there. Because
I just wanted to
avoid.
I want to wear you out.
You wanted to avoid
most big guys. I mean, most big guys don't get past round 3. But from a relevant standpoint, you asked me about metabolic health.
Yeah, of course.
And it really it feeds into a major risk category.
Yeah.
That it matters, right?
A couple of things on here right away. If you look at insulin, right away we're going back. There's insulin. There's hemoglobin A1C. Those things that we have kind of talked about multiple times. ultimately
Yeah.
what we're looking at there is problems with hyperglycemia. We're
Yeah.
talking
Sugar
about
balance.
diabetes, pre-diabetes.
Yeah.
Why don't we again just emphasize this link between hyperglycemia and diabetes and increased risk?
Oh yeah. I mean, so that's a really good question.
Yeah.
So or let's just not even use the word diabetes. Let's use the word insulin resistance.
Insulin resistance
Yeah.
basically resulting in hyperglycemia.
Yeah.
Yeah.
So insulin resistance, hyperglycemia, metabolic dysfunction. So like literally mitochondria become less efficient. Your energy metabolism pathways shift more towards fat deposition, truncal obesity, inflammation, cardiovascular risk, right? I
Right.
mean, that's kind of how I would map it if I had a whiteboard in front of us. But it's extremely linear.
Right. One of the big
Yeah.
things too, I think, like going back to the word inflammation that everybody loves to use, when I think of hyperglycemia, I think of inflammation. I think of like systemic inflammation.
Yeah.
We did an entire episode when you were not here, Ben and I, about hemoglobin A1C. And
Hmm.
hemoglobin A1C, the way I described that was it's a way of measuring um, proteins getting slimed by
Hmm. By
high
sugar.
sugar, right?
Hmm.
And when proteins get slimed, they don't work as well as when they're not slimed. So a higher hemoglobin A1C means more proteins have been slimed. And in this regard, the sliming actually is kind of like um, is altering proteins, and it becomes part of this inflammatory pathway because now you've got proteins that are maybe getting some immune response,
Hmm.
something like that. So so bottom line is, again, as we've talked about multiple times now, hyperglycemia, insulin resistance, diabetes, all sort of on this, this same spectrum what we're
Oh
talking
yeah.
about, all have a significant effect,
Yeah.
ultimately either through the immune system, through
Yeah.
inflammation, and cause this effect of increasing risk of
Yeah.
cardiovascular disease, right?
Correct.
So we've covered insulin, hemoglobin A1C. Another
Yeah.
thing related is C-peptide. You want to
Yeah.
talk about C-peptide a little bit?
Sure.
What is that?
Yeah. And how it correlates to insulin. So insulin is produced by the beta cells of the pancreas. C-peptide is also released in a 1-to-1
Yeah.
ratio. So it basically just shows that insulin's being produced.
Yeah. So in other words, if your insulin and your C-peptide didn't match up, you might be getting your insulin from some other source.
Yeah.
Okay, so that's fine. The next thing, insulin resistance score. Basically, and just to belabor this, but basically what your insulin resistance essentially is what we're talking about when we talk about diabetes, type 2 diabetes.
Yeah. Type 2.
It's just what it sounds like. Like how resistant are your are your cells to actually insulin working, and the more resistance it is to insulin working, the worse control of your blood sugar there is,
Yep.
right? So
Exactly.
that's basically that.
So
Okay,
the GLUT transporters, so how effective are the transporters to get
right,
glucose out of the blood?
right. Um, Okay, so I wanted to kind of move through those blood sugar ones quickly, but again, the moral of the story is high blood sugar, insulin resistance, all this stuff, big cardiovascular
Without a
risk.
doubt.
The next thing is really interesting. We've talked about it before. The measurement is for homocysteine. Remind us what homocysteine is.
Homocysteine is a byproduct of the methylation cycle. Methylation is simply the process by which we create a methyl donor, and those methyl donors go out and they give their methyl groups to certain enzymes and certain proteins to turn them on and turn them off, right? So it holds immense value, but in a nutshell, homocysteine is one specific location on that methylation cycle to show that it's spinning. If homocysteine is high, it means that there's a problem somewhere in the methylation cycle.
The bottom line is, in terms of what that whole thing that you just mentioned was, that homocysteine is something that is a byproduct of something that isn't working. That
Yeah.
when it's not working, you're at a higher risk for cardiovascular disease.
Yeah.
Right?
There you go.
In effect. I mean,
Yeah.
just so people have a sense of what that
Yeah.
is. Now, this is important though, because for 30% of the population, 30% of the population has a mutation that makes it so that there is higher levels of homocysteine, and that's because of a mutation in something called the MTHFR gene. Again, we've talked about that before and how medical students used to remember that. But
Remind us.
in effect, though, if that gene is not working, your homocysteine will be elevated because your body's not doing what it needs to do in that pathway, and it's leading to increased risk. Now, here's the thing. As I've mentioned before, I am out of the closet about this. I have MTHFR mutations. Okay? I have an MTHFR mutation, and I was just looking this up. Previously, my homocysteine level was 9.4, and when we basically decided to do something about it, and the simple thing we did, what do we do?
Yeah. We put you on methyl protect.
Yeah,
which
methyl
is
protect, just
folic acid, like activated folic acid.
methylfolate, right?
Yep.
Methylfolate. So methyl protect, and boom, those numbers came way down. They weren't super high before, actually, because I think normal is still 11.4. So I must have had, maybe one gene
Yeah,
that,
you did.
one because generally obviously you're gonna have two genes, one from each parent, so you could have a mutation on one of each one. Maybe I had a mutation on one of them. Homocysteine was a little high, or on the higher end of normal.
Yeah.
Now it's not. So, but bottom line is, that is again one of those things that we've talked about before. It's low hanging fruit. All I had to do is take a B vitamin
Yeah.
and potentially,
Yep.
lowered my risk of cardiovascular disease.
Independent
And
risk
that's the
factor.
kind of thing that monitoring yourself and taking
Yeah.
advantage of this ability to do diagnostics and medicine 3.0 is such a big deal. That's a great example of that. Okay, so the next thing in this is vitamin D. Now, this one, I feel like, I don't know if this is even really fair when we actually go in for the battle, because it's kind of like one of these, these things, right? Like, so what? Okay, so vitamin D. Talk about vitamin D. Why is it important? Who cares?
Yeah,
And all that
well,
kind
I
of
mean,
thing.
vitamin D holds lots of different, some people even call it a hormone, by the way. So vitamin D holds several different physiological effects on the body. The classic one that we all are aware of is bone health.
Yeah.
And part of that is the reason that vitamin D acts on your gut to increase calcium levels. It acts on your bones. It acts on different sort of areas on your body to optimize physiology of bone health,
Right.
right? But it also has a greater role in hormones, and it's in this simply because of its emergent role in cardiovascular health.
All right. So let's move on here, though. So vitamin D. We have vitamin D here.
Yeah.
Why is vitamin D on metabolic markers
Yeah.
for
Why
cardiovascular
is it on the
disease?
cardio IQ score?
Yeah.
Well, the answer is that we're learning that vitamin D goes well above and beyond just simple bone health. Actually implicated in vitamin D deficiency, it's implicated in endothelial dysfunction.
So endothelial cells are the cells
Yeah.
of the blood vessels.
Yeah, the
So
inner lining of the blood
the
vessel.
inner lining of the blood vessels.
Yeah.
So dysfunction means not functioning well. So
Yeah.
again, that cardiovascular
Yeah.
disease, right?
Yeah. And so cardiovascular. So and that includes blood pressure. So endothelial dysfunction. So if the endothelium of the vessels, I mean, this is actually a really good point, holds a tremendous value, and they actually have to be extraordinarily healthy to dilate and close. And if they don't, if they get rigid, then you're more likely to develop high blood pressure, which is
Right.
a risk factor for cardiovascular disease.
Right. So it can
Yeah.
become like a cyclical thing.
Yeah.
Right.
And then don't forget insulin resistance. which
Right.
is we spend a lot of time
Right.
talking
So
about.
vitamin D also affects
Yeah,
insulin resistance.
yeah,
Vitamin
sugar
D is one of those
metabolism.
things that like seems to have a significant role in a lot of things. So it's actually not a big surprise
Yep.
that it falls in this category as well. What's interesting, and maybe you can comment on this, but was it you who told me that like for some reason everybody in Montecito has low vitamin D?
Yeah, I
And
actually
it's
did.
weird. I mean, it's basically Southern California where everybody's outside all the
Yeah,
time,
I know.
right?
So yeah, vitamin D homeostasis or physiology is quite complex. It's not just all sunshine, So the precursor to active vitamin D is made in the kidney, and then active vitamin D 125 hydroxyl vitamin D is produced from sunshine. But it is an interesting observation that I've made. I check vitamin D on all my patients because, number one, I've caught deficiency extraordinarily frequently, and number two, we're actually shooting for higher levels than just the bare minimum.
Yeah.
So 30 is the
But
cutoff.
was that different from where you trained? I mean,
Correct.
yeah, so there's something about
Correct.
this strange affluent Southern California suburb that's driving. You ever thought, I mean, I'm
I
sure you
think
have no
money
reason
begets the
why.
vitamin D deficiency.
Yeah.
No, I think if anybody, I think it's a problem of this. I think most doctors just aren't checking it.
Yeah.
Insurance doesn't like to cover it. It's actually extraordinarily expensive,
Yeah.
if insurance doesn't cover, but it's not the standard of medicine 2.0 care.
Yeah.
So I think it's an observation that I'm coming across simply because classically most doctors don't check it, including myself historically.
Right. Right. Well,
Yeah,
that's interesting. So, I mean, that's something that I'm low on as well. I
me
take like
too.
10,000 IU
Yeah.
per day, and that keeps me so that I'll probably have a better score than you, as we'll discuss in just a moment. Okay, so
Yeah.
let's go back here and let's take a few swipes at and Ben, what's the score so far? Ben?
Mm. Oh, it's
What?
getting close.
To 7? No.
Yeah, during the break, Ben and I just we recalculated the
There's
scoring
no
system.
way.
Yeah, the
Huh?
2
Oh,
pointers.
you didn't count them. It's not 9 to 7.
No, I think that sounds about right.
No, he's saying that because I was destroying him. I think you're totally wrong. Ben is wrong about this. Okay.
Yeah, we'll go
Ben's
back.
okay. All right. So don't believe him. We're going to believe the numbers that are on the screen. Okay? Because I'm quite convinced that Ben is wrong about this because I was embarrassing you throughout the whole
Not what I
time.
recall.
Yeah, okay. Yeah, well. All right. Okay. So,
So how are you looking?
okay. So, let's say insulin. Let's do the intact insulin. So lower is better. What do you got?
Yeah, I got 6.
I got 6. Okay, it's a draw.
Okay.
All right. Let's not do C-peptide because that's just the same
Yeah.
thing. Insulin resistance score.
Mm,
What do you got?
10.
Ooh, I got 17. Both good scores, but
Both of
yours
them are
is
good
better.
scores. Yeah.
All right. You caught
Yeah.
up. You caught up there. Not as much as you think you do because Ben hasn't been keeping score properly. You probably paid him off. Okay. Hemoglobin A1C.
5.1.
Ooh, I got 5.2.
Yeah. So, both great scores, right? And so
No, yours is actually better. So
well, I'm just
it's
trying to
not,
throw
mine is
you a
not
bone.
great.
I'm
There's no
just,
second place.
yeah,
There's only a winner and a loser. This
Yeah.
is not, I know you're a millennial, okay, but I'm playing by Gen X standards.
I grew up in the generation of trying to make people feel good. Yeah, I'll give you a second place ribbon.
Okay, 5.1 to 5.2. Our target actually is 5.2.
Yeah.
So maybe I should actually get extra points just because I'm at the target.
Well, I don't
No.
know about that.
Okay.
Yeah.
All right. Well, 5.2 is target. He's even better than that, so
Yeah.
that's good. Homocysteine.
Mm.
I might get hammered on this.
7.5.
Ooh, 6.3.
Yeah. See?
Yeah.
Right, but that's on your medicine, and that's actually an impressive
That's
improvement.
well, there
Yeah.
you go. But that's the beauty of it is
Yeah.
that you get to use all the possible aids that you want.
I like that.
If you want to come back after being on a little bit of
Yeah.
methylfolate, then we can rehash this out next quarter. Okay. Of course, Ben walks out just as I scored another point. And
Oh yeah, no, that's not going to be on the
okay, there
official
you go.
scorecard.
Okay, the scorecard. Yeah, there you go. All right, the next one we talked about. By the way, Ben, homocysteine, I won that one. Okay, the next one, vitamin D.
I got 41.4.
This one is a tricky one. I'm not even
Yeah.
going to take credit for this 64.8 here, because it's not because we're trying to get higher here. We're actually trying to stay within a range.
Yeah.
Right? Because
Yeah.
you wouldn't want to go crazy high. So Ben, I'm not even going to take credit for
Yeah.
that one.
So
I
it's
think I can win
binary.
this
Are
without
you within target or you not? I mean, that's a
within
good
target
point.
or within target. There's no prizes for having higher vitamin D.
Yeah.
Yeah. Not even for millennials. Okay. The final okay, and then finally insulin. We already did insulin, didn't we?
Yeah, we did.
Yeah, okay. We're good.
Yeah.
We're good.
Oh, we did intact insulin.
Yeah. What's
Yeah.
the difference?
Oh gosh, I have no idea.
Yeah, just leave it. It's all good. So the next thing we're going to talk about, it's the final thing on the cardio IQ. And this is actually a really fascinating thing. And it is APOE genotype. All right. So what is APOE genotype?
Well, apolipoproteins. So so the genotype that you're referencing,
A genotype basically means
what is a genotype?
So a genotype is what? Tell us what a genotype is.
Yeah, so we have two alleles. An allele is one variation of a gene that you get from one parent, and the other allele is the variation of the
Right.
gene, and the genotype is what you get, your
Right.
genetic disposition.
Right. Okay. So your APOE genotype, there are effectively 3 different kinds of these genes that you could
Yeah.
have.
Yep. 3
What are
alleles.
those?
Yeah, the 3 alleles are E2, E3, and E4.
E2, E3, and E4.
Yeah.
Talk about each one of those from a cardiovascular
Yeah.
perspective first.
So yeah, good question. I mean, so what are they? I mean, so literally these are apolipoproteins, but E2 confers a genetic protection from cardiovascular disease.
Yeah. Sort of like a
Yeah.
get out of jail free card a little
Yeah,
bit.
right,
Yeah.
right. I mean, so these are patients, if you have an E2 genotype, that have lower cardiovascular outcomes.
Yeah.
E3 is what we call wild type. It's the most common allele in the population. Most patients are E3, E3.
Mhm.
If you're an E2, E3, you're at an advantage. If you're E2, E2, you're at a higher
So
advantage.
E2 is actually sort of like, you kind of won the lottery. It's not normal.
Yeah,
It's actually
protected.
lower than average risk of cardiovascular
Yep.
disease. So that's why I called it a get out of jail
I think
free,
that's appropriate.
right? And so the three is
Averages.
average. And then what's 4?
Yeah, so E4, you don't have a disadvantage from a cardiovascular standpoint, but you have a disadvantage from a neurological standpoint. So E4 is the classic Alzheimer's risk gene. So, or I should say allele, right? These are all ApoE genes, but the E2, E3, E4 dictate alleles.
Right.
But if you have an ApoE4 allele from either mom or dad, then you're at a higher risk of developing Alzheimer's, early onset Alzheimer's.
So the way these things are reported typically is like, 2 numbers. So one from mom, one from dad.
Yeah.
And so if you can think about it, like if you had the wild type, as you mentioned, the normal, the most common is 3-3.
3-3.
Happens to be what I am. And in
Yeah.
this one, you didn't actually do the test,
Yeah.
right?
Yeah, I didn't check
Otherwise,
that
I probably
box.
would have beat you.
I think
But
being a poor doctor, I want to save the $30.
so we're 3-3. But if you were 2-3, you would have slightly less risk than a
Correct.
normal person.
Yeah,
If you were a
relative risk.
2-2, you'd be like a cardiovascular stud.
Yeah,
Right.
Adonis.
And you could pretty much do anything and have no issues. Right. You could be like downing butter.
Yeah.
You could be doing anything you want. You'd be
Right,
fine.
right.
But you would anyway. You'd have lower risk, and then but the 4 is I think where it gets pretty interesting, because if you're 3-4, so that means you have 1 wild type, 1 normal,
Correct.
1 4. We said that the 4 actually confers higher risk of Alzheimer's disease. How much Like, so you're three, say you have 1-3 and you got 1-4. How much
Yeah.
more likely are you to develop Alzheimer's disease than a 3-3?
Yeah. So that 1-4 puts you
Yeah.
at over 25%. Or let me put it in terms of relative risk. So we're talking about 2 to 3x
2 to 3
increase.
times more risk
Yeah.
of getting Alzheimer's disease. Isn't that specifically related? Is it specifically earlier onset too, right? I
Yeah.
mean,
These patients are more likely to get early onset,
yeah.
which
So
is
like
also
in
more
middle
dramatic.
age,
Middle
you
aged.
know,
Yep.
40s, 50s,
Which is really
60s,
scary.
that kind of
Right.
thing.
Correct.
Right. Um, Now, is this Alzheimer's? You may not know the answer to this, and I'm sorry if you don't, but
Mm.
is it just Alzheimer's disease or is it all dementia?
No, this is Alzheimer's.
This
This
is
is not,
Alzheimer's.
no, this has nothing to do with
So it's not
vascular
like
dementia.
diffuse Lewy body dementia or anything
Yeah,
like
I mean,
that.
that's a really good point, right? I mean, these are apolipoproteins, so
Right,
theoretically they also affect blood flow and other
right,
things, but we're not talking about vascular dementia right now. We're talking about
right,
Alzheimer's
right,
dementia.
right. Okay. And then,
Mm,
so now you said 2 to 3 times the risk for one
correct.
ApoE
Four.
gene allele.
Yep.
If you end up with a 4-4,
Yeah, that's unfortunate.
yeah. So what's
Yeah.
your risk then?
Yeah, we're talking about 12x or more. So yeah, 12 to 13x is really kind of where their data
Yeah,
is. Increase in probability of developing Alzheimer's.
yeah,
And you know, this is so you said early onset. These patients are more probabilistic to get it at a younger age, and that has to do with the critical threshold of the tau and the NFTs, the neurofibrillary tangles.
yeah,
So they develop at a higher rate, so you get it at a younger age,
yeah,
but they also get it at an older age too. So really, so this is all Alzheimer's dementia, 12 to 13x.
yeah. Even though we're on this cardiovascular topic, I think it's important just to mention because it was just in JAMA, Journal of American Medical Association, interesting article because you hear about like early onset Alzheimer's. Everybody's afraid of Alzheimer's. It's like living a
Yeah,
long time. If you live long enough, you're very likely to get some kind of dementia at some point. But
true, true.
but this was sort of some promising news about
Yeah,
Alzheimer's disease
donanemab.
treatment. What was that
Yeah.
study about?
So donanemab, you're talking about. So
Yeah,
right, so this is the new class of monoclonal antibodies
yeah,
that are targeted to mild to moderate
yeah,
Alzheimer's,
yeah,
and really, we have statistically significant decrease in progression of Alzheimer's
yeah,
to the higher classes.
yeah. So this stuff
Yeah,
actually literally removes amyloid plaques, the
yeah.
stuff that is
Which is astounding.
that actually we look at on MRIs to give somebody a diagnosis of Alzheimer's
Yeah,
disease. Um, so we won't go into it
yeah.
in detail, but there's a few more drugs on there. I have a friend who's a neurologist, and we're gonna come back and talk about those
Awesome.
drugs and that at some point. So that was really good news. The other thing, as long as we didn't mention it last episode, I don't think we talked about it, but one of the few points in which you actually beat me was cardiovascular inflammation, high sensitivity CRP. Um, Mine was slightly above normal. And the idea there again was inflammation has a role in cardiovascular disease. There was another study, all right? There was another study. Do you want to talk a little bit about, and I don't, just mention to what this role of colchicine,
Oh, that's right.
the colchicine study. If you, I know I just am giving it to you, so don't,
Yeah.
I don't expect you to know all the details of this stuff, but I know you read it.
Yeah,
What's
no,
the
I did. I
upshot
got the
there?
pointers for it. So colchicine has anti-inflammatory properties. It's not a classic NSAID,
Right.
but
Normally
literally,
it's a drug for gout.
yeah, yeah. I mean, it's a
Yeah.
microtubule inhibitor. So
Yeah.
initially, it was FDA cleared for chemotherapy
Yeah.
and then used for gout, and we use it for pericarditis and other sort of cardiac inflammatory
Yeah.
issues. But yeah, just recently FDA cleared for cardiovascular risk, primary prevention.
What's interesting about
Yeah,
that too is that, we've been talking even in today's discussion, yes, in our last episode's discussion about the role of inflammation throughout cardiovascular disease. This is the first FDA cleared anti-inflammatory drug for cardiovascular disease.
yeah. I mean, that's right. And what I found most striking about that is generally the anti-inflammatory class of
Yeah.
medications were contraindicated in cardiac disease. We would use it like, as a resident. I remember even getting yelled at, a patient of mine in the ICU, in the coronary ICU, day 2 after, I
Right.
think it was I don't think it was heart surgery.
Uh-huh.
Maybe he just had a cath procedure, but he had a headache and I gave him ibuprofen. Sure, why not? Let's cure your headache. And I got reamed out by the senior resident or the fellow for giving an NSAID to a cardiac patient. And now here we are
Yeah.
given an anti-inflammatory
This is
medication.
not colchicine though
It's
works
not an
probably by a
NSAID.
little bit different mechanism.
Yeah,
It's still an anti-inflammatory, but I don't know if it's
yeah,
an NSAID, right? So
yeah. You're right. It's a different class.
yeah.
Yeah.
So I guess the question, and you haven't had a time to digest this, but one of the things I'm curious about, and I mean, you are my physician here. At some point, I'm going to ask you whether I should be on low-dose colchicine because, I mean, obviously, when you look at the cardio IQ, I did pretty well. I mean, I certainly compared to you. And but the one thing that if there was one place that I might have some slightly elevated number, they're not elevated though. Actually, this is a
Yeah.
moderate, but it's not
Yeah.
optimized.
Yeah.
The question is, would it be worth going on something like colchicine at a low dose? But
Yeah.
is there what's the safety and side effect profile of that medication?
Yeah, I mean, the safety profile is actually pretty reasonable, by the way, in the absence of
Uh,
renal failure,
yeah,
which you don't have, right?
I
But
don't think so.
no, I'm not
You would
worried
have
about.
told me, right?
Yeah, no, exactly. You would have known. So I'm not worried about from that perspective. But what I would say would be, I would like to see follow-up trials before I put you on it. Now, if you have a problem of inflammation, we can easily start, especially, you're talking about mild elevations and
It's
you're
a
not
mild
even in the
elevation.
pathological. What sort of natural supplements, what kind of homeopathic mechanisms do
So
we have?
curiously, this was 6.5 before.
Yeah.
It was very high
Yeah.
before,
Yeah.
like a year ago.
Yeah. You're talking about the CRP, the HS-CRP.
No, yeah,
Yeah.
yeah,
So look at that. I mean, even your lifestyle changes and your vitamin supplement that you've been put on since then
yeah,
has showed that dramatic of an effect. So, not to discount colchicine, I would say let me digest the article in detail, kind of go
yeah.
through the details of it, and then let's keep an eye on follow-up studies that actually support the claim for primary prevention.
Pretty interesting
Mhm.
stuff, man. I think we have like really beat the heck out of the cardio IQ,
Yeah,
and
and
I don't know exactly what the final score is. It's up on the board right now, but I'm guessing I defeated you. But we'll
yeah.
be ready for a rematch.
Well,
Um,
since this one though, I don't know if you've really done anything different. I've got a whole slew of things that I've
Well, I mean,
implemented.
you can try. You can try. I think you should. You think you should give it your best shot. Actually, we're pretty much due for it. I mean, like it's like a quarter. It's like 4 months.
Yeah,
We probably in September, maybe in October or something. In 6 months, we could do
yeah,
a rematch.
perfect.
And see how that goes. The other thing, maybe the actual CT thing that we're getting. What's that?
Oh yeah, you're talking about the Cleary, the CT
The
angio.
CT angio. We could
Yeah, with
also have a
AI.
battle of the CT angio
Oh,
if you
that would
want.
be really interesting. But I mean, we'd have to normalize for what, an 8.5 year age difference. So, how do
Oh,
we
now
account
you're
for
calling
that?
me old.
We
You
got
don't
a
have to
monumental
normalize
year coming
anything,
up.
buddy. All right.
I'll give you a 20% advantage on it. Whatever I get.
Anyway,
Yeah,
good time, buddy. Thanks
always
for
fun.
joining us. Thank you for coming to our round 2 of Cardio IQ. And we'll see you next time.
Thanks, buddy. Appreciate you inviting me.